Hello, I'm Peter Libby from Boston's Brigham and Women's Hospital and the Harvard Medical School, and it is my honor to moderate and open this webinar on management of patients with statin intolerance. If I could get my slides up, please. So we're very fortunate to have a webinar that is sponsored with a grant from Esperion Therapeutics. And I'm joined by my colleagues, Erin Michos from the Johns Hopkins Medical School and Steve Nicholls from Melbourne, Australia. We're going to have some presentations followed by discussion, and we invite you to put your discussions in the question bar at the bottom of your screens. So just to set the stage, I'd like to remind you of how fundamental and important LDL is. I think I need you to advance the slides. Yes, I'm going to speak about LDL as a causal risk factor in atherothrombosis. These are my disclosures. This slide says that I consult broadly, but I do not accept any personal payment from any pharma or device company. Well, I'd like to think of the atherogenic lipoproteins as members of the apolipoprotein B family, with the fundamental member of the family, the founding member, low density lipoprotein or LDL. Multiple lines of evidence show that low density lipoprotein, cholesterol, is causal in cardiovascular disease. We have decades of observational epidemiologic studies. We have very strong human genetic evidence, not only with the monogenic causes of hypercholesterolemia, which you're all familiar with, but also we learn that less rare variants, but causing each a small effect on LDL, can associate in accumulation with increased cardiovascular risk. And then we have a wealth of randomized clinical trials where we have used various ways to lower LDL in human beings and shown a wide variety of endpoints are improved. And in the aggregate, we're able to show a mortality benefit. And then finally, from a mechanistic perspective, we have a plethora of animal experiments that support the causality of low-density lipoprotein in atherosclerosis and have permitted us to gain a great deal of mechanistic insight into the pathways which promote atherothrombosis in animals that have increased levels in their bloodstream of the atherogenic lipoproteins. Now, one key issue which we must always bear in mind before we embark on a discussion of pharmacology is that lifestyle is a key to cardiovascular prevention. However, in many of our patients, lifestyle is not enough to achieve an appropriate control of their cardiovascular risk factors. And that's why we're very fortunate to have a full palette, a growing palette of therapeutics that can lower LDL effectively. We have bile acid sequestrants that were perhaps first out of the gate, but they are not only impalatable, but also can increase the triglycerides, even when they were studied in an era before we have prevalent diabetes and obesity. Statins, however, are the foundation of LDL treatment and really should be at the bottom of the pyramid for treating LDL in patients who are able to take them. We are fortunate to have the addition of cholesterol absorption inhibitors, the inhibitors of NPC1L1, which is a transporter for cholesterol, dietary cholesterol from the gut, and plays very well with statins. So we have good clinical trial evidence that the additional decrement in LDL when we give an agent such as ezetimibe to the statins can improve cardiovascular outcomes. I guess I need some help building this slide. Okay. And then in the last few years, we've seen the advent of antibodies and now a small interfering RNA therapeutic that can target proprotein convertase subtlysin kexin type 9, known by its friends as PCSK9. And we know that we can have really striking decreases in LDL, even on top of statins, by the administration of these biological agents that can decrease PCSK9. And we're very fortunate to have a new addition to the family of LDL therapeutics. If you could build this slide for me, and those are inhibitors of ATP citrate lyase. And Dr. Nicholls will tell us about that in a moment. So it's been very interesting for those of us who've been in the field for a while to witness the evolution of the LDL lowering therapies. We don't even mention on this slide that I did together with my colleague and friend, Professor Lalit Tokosoglu from Ankara, Turkey, that doesn't even show the resins for the reasons which I told you about. But those were the agents that were used in the pivotal lipid research clinic in the early days of therapy of LDL. We have the statins, we have ezetimibe, we have icosapent-ethyl, bempedoic acid, which you'll hear about, and the fibrates. And then we have monoclonal antibodies, we have antisense oligonucleotides, ASOs, we have small interfering RNA. There's always the promise that we may have a vaccine that can lower LDL, something which has been pursued for 20 years, and we actually have not had this cross the threshold of clinical utility yet. And then the very exciting possibility of gene editing, which could be a one and done approach to alleviating the ravages of high LDL cholesterol. Although the statins remain appropriately the foundation of managing cardiovascular risk due to LDL, somewhere around 10% of patients are unwilling or unable to take statins. And we'll hear about that in the next talk. So, how do we approach patients who are statin intolerant or statin reluctant? And in my own referral practice in a quaternary center, somewhere between a third and 40% of my patients are very reluctant to engage with statin therapy. And it is a constant uphill battle for me to get many of my patients to agree to take statins. So, on behalf of the International Atherosclerosis Society, I'm very happy to welcome you here. And I'd like to introduce our next speaker, Dr. Erin Michos from Johns Hopkins, who's going to talk to us about statin reluctance resistant intolerance. Erin?
Thank you very much. I'm honored to be part of this webinar. These are my disclosures. I'm going to start with taking it over where Professor Libby left off about LDL cholesterol being causally associated with atherosclerotic cardiovascular disease, but also the importance of getting lower LDL for longer periods of time. So what this slide shows is that there's a proportional relationship between the magnitude of LDL lowering with proportional reduction in coronary events. but time matters. I have a black line here at 1 millimole per liter of LDL, or 39 milligrams per deciliter. And the top black line shows genetic studies. So for that same 1 millimole per liter of LDL lowering in genetic studies, you confers about a 50% reduction in coronary risk, likely because these individuals have had lower LDL from birth. On the other hand, if you look at the red line, these are randomized clinical trials, on average about 5 years in duration. So for that same 1 millimole per liter lowering, because over a shorter time period, it confers about a 22% reduction in major adverse cardiovascular events. So still proportional lowering, but getting lower for longer matters. And this is shown pictorially in this figure. I like to think about cholesterol years in the same way we think about pack years of smoking, that it's not only the magnitude of elevation, but it's the duration of exposure to that elevation. The dotted line here represents sort of a theoretical burden of cholesterol years where you would have the clinical onset of ASCVD. Some have thought this is around 5,000 milligrams per deciliter years. So, individuals in the red line who have severe hypercholesterolemia, such as those who have FH, who've had high cholesterol from birth, if untreated, they will cross over this threshold of clinical ASCVD early in life. Now, contrast that by the individuals shown in the green line who have lifelong low LDL, either through favorable genetics or healthy lifestyle or early initiation of LDL lowering therapy. They may never cross that threshold to develop a clinical ASCVD event. But I think we do need to pay more attention to those in the yellow and the orange who have mild to moderately elevated cholesterol. Often these individuals kind of get ignored or overlooked, but with sufficient years at this exposure, they too will have earlier onset ASCVD compared to their counterparts who've had lifelong low LDL. Now, statins remain the first line pharmacotherapy because there's overwhelming evidence that they reduce risk in both primary and secondary prevention. But even though they reduce risk, we see in the statin treated groups here in the blue that events still do occur, although less frequently than the placebo group. But we call this residual risk. This residual risk, a risk of recurrent events, can be due to other non lipid factors, such as suboptimal control of hypertension or diabetes or smoking or inflammatory residual risk. But some of this residual risk is due to residual burden of atherogenic lipid particles, because we have seen from randomized clinical trials of non-statins added on top of maximally tolerated statins that if you can further lower LDL, you can further reduce risk. And we saw this with the Improve It trial here on the left with enzetamide. We saw it with the trials of Fourier and Odyssey outcomes with the PCSK9 inhibitors, that on top of maximal statins, further LDL lowering can lower risk. And the PCSK9 inhibitor trials were relatively short duration, around 3 years, and the curves are widening. And with longer follow up, the benefit continues to accrue. Now, unfortunately, despite all this data about the importance of LDL lowering, there's a lot of inertia, and many high risk patients are not at goal. This is US data from the Gold Registry of ASCVD patients. So, this is a secondary prevention population, and the majority are not at goal. In fact, over 2 years of follow up, only 17% had their lipid lowering therapy intensified. So, there was a lot of inertia, and two-thirds of these high risk individuals with ASCVD remained above an LDL threshold of 70 milligrams per deciliter. And I circled here the PCSK9 inhibitors in the red, just showing the low utilization of these therapies. So combination therapy is very underutilized. This was another study from the US from a large payer system. So these patients had insurance, but half of these patients with ASCVD were found to not be taking a statin, and less than a quarter were taking a high intensity statin, the appropriate intensity statin for a secondary prevention population. Some of the factors associated with being less likely to be treated with a high intensity statin was female gender, older age, more comorbidities, or having cerebral vascular disease or peripheral vascular disease as opposed to coronary disease. So lots of patients are suboptimally treated. And this slide outlines some of the factors affecting statin non adherence and poor LDL control. And some of those drivers are therapeutic inertia. Unfortunately, there's a lot of misinformation in the internet, but there's also statin associated side effects, which is what I'm going to focus on next. And there's possible solutions to address these key drivers. So, the National Lipid Association released a statement of how they define statin intolerance, and their definition is having one or more adverse effects associated with statin therapy. It's most often myalgias that resolves or improves with dose reduction or discontinuation. And to get this definition, you have to have tried a minimum of two statins, including at least one at the lowest approved daily dose. Now, note that complete intolerance, where a patient can't tolerate any statin at any dose or any regimen, is actually pretty uncommon. Less than 5% of patients with statin intolerance have complete intolerance. The majority of patients with statin intolerance have partial intolerance, which means they can tolerate some statin, but it's at a lower dose than is required to achieve their desired therapeutic objective. But because partial intolerance is much more common than complete intolerance, it's always important that we re-challenge patients and try to get them back on some dose of statin. Now, across studies, the prevalence of reported statin intolerance has widely varied, anywhere from 3 to 30%. But in this meta analysis of nearly 200 studies, over 4 million patients, the average prevalence of statin intolerance was about 9%. Factors associated with statin intolerance was older age, female gender, non-white race ethnicity, high exercisers, and those with some chronic comorbidities like liver disease and kidney disease. Now, one of the challenges is that, and I'll talk about the nocebo effect, but it's been sort of debated a little bit about how much of statin intolerance is really causal. In placebo-controlled trials, and granted, many of these trials did have a run-in phase, but in placebo-controlled trials, there was actually not any signal for excess withdrawal of statins for side effects compared to placebo when patients were blinded to therapy. So we know about the nocebo effect, the opposite of the placebo effect. The nocebo effect, when patients are anticipating a treatment is going to be harmful to them, then they perceive negative symptoms. And we saw this demonstrated very clearly in the Samson trial, as well as some other similar trial designs. In Samson, it was a small study of 60 patients, but they was N of one. They served as their own control, and they all had statin intolerance. And they were given 12 months of therapy. For 4 months, they would be on a statin. 4 months, they would be on a placebo match control. And for 4 months, they had empty bottles and didn't take anything, and they knew they weren't taking anything that month. And yes, they did have more muscle symptoms the months they took the statin compared to the months with no treatment. But 90% of their symptoms were elicited by the placebo tablets too. And so this data suggests that side effects of statins may are mainly caused by the act of taking them, not by what is in them. And so it's always worth doing a statin re-challenge. Now, there are significant consequences of statin non-adherence. On the figure on the left, this is from a VA study of secondary preventions who all had ASCVD. And in the VA system, they have a pharmacy linkage so they can show medication adherence, the medication possession ratio. And those adults that had poor adherence in the purple and green bars, they had increased risk of mortality. On the other hand, those that sorry, the increased mortality were in those that were had the lower adherence in the orange and the blue bars. On the slide on the right, showing sort of the opposite relationship, was a primary prevention study of older adults above the age of 75 who had their statins discontinued versus continued. And we see that those that had their statins discontinued here in the blue lines, they had a 33% increased risk of having a major cardiovascular event compared to the older adults who stayed on their statin. So age alone is not a reason to stop a statin, and these patients were more vulnerable for events. So, we know that drugs don't work in patients who don't take them. So, adherence remains a great challenge in the treatment of lipids. And again, one of the solutions is to try a rechallenge. As mentioned, many patients with a history of intolerance can tolerate some statin, and this was data of over 1,600 patients referred to the Cleveland Clinic for the indication of statin intolerance. And they were able to get, the majority, 73% of their patients with prior statin intolerance back on a statin, and stayed on a statin for 31 months. And indeed, with longer follow up, those that were remained on the statin, either daily dose or non-daily dose, had a trend for a better survival compared to those who had their statin was discontinued. So the National Lipid Association has published this algorithm for management of statin intolerance. It includes things like screening for other causes of their myalgias, really educating the patient about the benefit of the statins, their long-term risk reduction, um, you know, uh, trying holding the statin, seeing if the symptoms resolve, and then introducing a re-challenge, restarting at a different statin, maybe with different pharmacological properties, or again, starting at a lower dose, starting an alternate regimen like every other day statin. But ultimately, especially in high risk patients, we know we need to get to goal faster. And so when we really tried and patients remain above their therapeutic objective, you don't have to try all six statins in every possible combination, just need to move on. And fortunately, we do have some non statin therapies that can be added to the maximally tolerated statin dose. So, what are these new tools? You already heard about some of these from Professor Libby, and you're going to hear some more from Professor Nicholls. Um, Bempedoic acid, there in the upper left, works in the liver and the same pathway as statins, inhibiting the cholesterol synthesis. It inhibits an enzyme, ATP citrase lyase, that's upstream of HMG CoAce reductase, which is the enzyme that statins inhibit. So, by inhibiting cholesterol synthesis, reducing cholesterol availability in the liver, this leads to upregulation of LDL receptors on the surface of the liver and more clearance of LDL out of circulation. You heard about ezetimibe. This decreases intestinal cholesterol uptake, and that also leads to upregulation of the LDL receptor and more clearance of LDL out of circulation. On the right side of the slide, I've shown the PCSK9 inhibitors. PCSK9 is a protein in the liver that's involved in facilitating the degradation of the LDL receptor. So, by inhibiting this protein, either with the monoclonal antibodies or with inclisiran, which is a small interfering RNA that targets the mRNA for PCSK9. This leads, by inhibiting PCSK9, this leads to upregulation of LDL receptors, more LDL receptors on the surface of the liver to clear LDL out of circulation. So here are those major non-statins on the slide. Ezetimibe oral medication, you would anticipate about an 18% lowering LDL. As I mentioned, Improve It was the outcome trial for this agent. Bempedoic acid, you're going to hear a lot more from Professor Nicholls about the outcome trial, clear outcomes. But on a background of statins, they confer about an 18% lowering from this oral medication, a little bit more, about 22% reduction when there's not statins on board. And it also comes in fixed combination with ezetimibe, where it confers about a 38% reduction in LDL. The PCSK9 monoclonal antibodies given by subcutaneous injection every 2 weeks confers about a 60% lowering of LDL. And I showed you those outcome trials, Odyssey Outcomes and Fourier. And then inclisiran, that small interfering RNA against PCSK9. After the baseline and 3 month injections, it's given by subcutaneous injections just twice a year, every 6 months. And this confers about a 50% lowering of LDL. And although we don't yet have a published outcome trial for inclisiran, there's several ongoing, both in the secondary prevention and high risk primary prevention populations. So, just to take a step back to the 2018 AHA/ACC cholesterol guidelines, there really are four major groups that warrant LDL lowering. You have your secondary prevention patients with clinical ASCVD. You have your patients with severe primary hypercholesterolemia with LDLs above 190 milligrams per deciliter. This is a group that's really enriched with familial hypocholesterolemia. You have your patients over the age of 40 who have diabetes who warrant a statin. And then you have this group on the right in the red that's a little bit more challenging. This is a group of pure primary prevention who don't meet the other categories, but they're at sufficient elevated risk that they warrant LDL lowering in the primary prevention setting. Now, even among secondary prevention, our guidelines has also distinguished a category of secondary prevention individuals who are at very high risk, where we have the most intensive goals. These are individuals who've had either two major ASCVD events, like acute coronary syndrome, myocardial infarction, stroke, symptomatic PAD, or have had one of these events and at least two high risk conditions that are so common in these patients, like older age or kidney disease, prior revascularization, diabetes, smoking, hypertension, or remaining with an LDL above 100. Now, I'm going to show you the more recent ACC consensus statement, but it really sort of mirrors this earlier European Society of Cardiology guideline that sets essentially two goals for these risk groups. The first is for these high risk groups to achieve greater than 50% reduction in LDL from one's baseline, but then to also achieve these treatment goals. And for these high risk patients, an LDL less than 70, and for those patients at very high risk that I just discussed, an LDL less than 55 milligrams per deciliter. So to get to those lower goals, we really need for most patients, be thinking about combination therapy. And we have a lot of different combinations that we can do between the non-statins and the statins. And really, if you know where you're starting and you need at least more than, if you're, when your LDL is more than 50% higher than your goal, to be thinking about combination therapy kind of very early on, right out the gate, just like we would use combination therapy if a patient had a systolic blood pressure of 160 millimeters of mercury or higher. You'd be thinking about combination blood pressure therapy. And then we need to follow them more closely. We really need to intensify or add treatments every 6 to 12 weeks until our goal is achieved. And so in 2022, the American College of Cardiology expert consensus decision pathway incorporated some guidance around the non-statin therapy, and they kind of reiterated these LDL thresholds, and similar to the European Society of Cardiology, that patients with very ASCVD at very high risk, the LDL less than 55, secondary prevention patients not at very high risk, an LDL less than 70, and adults without ASCVD, so primary prevention, but having baseline LDL above 190, so your FH patients, an LDL threshold less than 100. And we'd always start with a maximally tolerated statin. But unfortunately, sometimes for our patients with statin intolerance, a maximally tolerated statin may be no statin or only a little bit of statin. And then we would add these other non statins that we have discussed. Now, what about primary prevention? Our guidelines do recommend starting with some kind of global 10-year risk assessment. As a starting point, we do know that these equations have their limitations, but those who are already above high risk, above 20% 10-year risk, to be thinking about high intensity statins plus a lifestyle. But for those who are borderline or intermediate risk, to be looking at risk enhancing factors to help guide initiation of statins. And then a coronary calcium score can be useful if there's still uncertainty about risk, to revise the risk estimate and guide shared decision making. And so these are the risk enhancing factors, and I'm not going to read all those, but I was really pleased that they did include things like chronic inflammatory conditions and these female specific factors like preeclampsia and early menopause. And you can see the lipid biomarkers having a high CRP above 2, having a high LPA above 125 nanomoles per liter, high ApoB. This would all favor initiation of statins or intensification of statins if patients are already on them. And then there is a role for coronary calcium score if there is still some uncertainty about risk, and they provided some guidance around that. For those that have high calcium scores above 100 or above the 75th percentile for their age and gender, to target an LDL less than 70. For those with calcium scores 1 to 99 or less than the 75th percentile, an LDL less than 100. But for those with very high scores, such as those above 1,000, you're really thinking about high intensity statins and also things like PCSK9 inhibitors, really treating them intensively like a secondary prevention population. So, in conclusion, for LDL, lower is better for cardiovascular outcomes and longer duration of therapy is better. The management of patients who are unable or unwilling to take statins represents a challenging and frustrating clinical issue. But regardless whether this problem represents the nocebo effect or an actual intolerance, these high risk patients need effective alternate therapies. Non statin therapies provide the same risk reduction per millimole per liter of LDL reduction as statins do, and now they're recommended across society guidelines for their implementation. But unfortunately, implementation in clinical practice lags behind guidelines, and adherence remains still a great challenge. But we do have new options available to address this issue. And with that, I will turn it over to Professor Nicholls.
Thanks, Erin. Hi, everybody. And what I'd like to do is take a deeper dive on bempedoic acid and particularly highlight the results of a number of findings of the CLEAR outcomes trial that we've been able to present this year. This slide summarizes my disclosures. So to reiterate, bempedoic acid is a new oral agent that lowers LDL cholesterol. That does it by targeting a factor called ATP citrate lyase, which is essentially upstream of HMG-CoA reductase in the liver. Inhibiting ATP citrate lyase will upregulate LDL receptor expression on the liver surface and reduce LDL cholesterol levels. And where bempedoic acid fundamentally differs from statins is that it is injected as a prodrug, so it has to be switched on or activated in vivo, and the factor that does that is present in the liver but not peripheral tissues such as skeletal muscle. So you'll get cholesterol lowering without necessarily getting the muscular side effects that we see in patients treated with statins. We have data from genetic studies that suggest that targeting ATP citrate lyase should be cardioprotective. Mendelian randomization shows us that having less ATP citrate lyase is associated with a lower cardiovascular risk, and that lower risk is directly associated with the degree of lowering of either ApoB or LDL cholesterol levels. If we look at a 2x2 type Mendelian randomization study, it would suggest that having less ATP citrate lyase is in fact even more protective on top of having less HMG-CoA reductase or less NPC1L1. So it would suggest that from a genetic studies that either monotherapy is bempedoic acid treatment should be cardioprotective, and also we should see potentially more protection in combination with either statins or ezetimibe. Here you see early data from the bempedoic acid experience. We see monotherapy LDL cholesterol lowering in the order of 20 to 25%, in combination with ezetimibe, lowering of LDL cholesterol in the order of 40 to 45%. And in fact, subsequent studies have shown that the combination of bempedoic acid, ezetimibe, and low dose atorvastatin has the potential to lower LDL cholesterol more than 60%. The CLEAR outcomes trial was presented at the ACC this year. To reiterate the design of that study, it was a large cardiovascular outcome trial of patients with high cardiovascular risk, LDL cholesterol levels of at least 100 milligrams per deciliter. But what was important about this study was all patients had to have documented statin intolerance. Essentially, they are either unable or unwilling to take guideline recommended doses of statins. And we required that both the patient and the clinician essentially signed a form acknowledging that at the start of the study. Patients were treated with daily doses of bempedoic acid or matching placebo, and this was kind of a conventional MACE study where we required a large number of clinical events to be accrued. Here you see the baseline characteristics of the study, mean age of about 65. Nearly 50% of patients in this study were women. That was something we were quite proud of from a clinical trial perspective. Baseline LDL cholesterols were 139 milligrams per deciliter, HSCRP levels 2.3 milligrams per liter. 70% of patients had clinically manifest ASCVD at study entry, 30% were high-risk primary prevention, 45% of patients had diabetes, and we did allow patients to be treated with doses of statins that were below the lowest daily recommended dose, and about 1 in 5 patients were treated with very low doses of statins. Here you see the biochemical changes during the study. You see favourable effects of bempedoic acid on both LDL cholesterol and hsCRP, as we'd seen in previous studies. Importantly, on the left, you can see that the LDL cholesterol effects narrow over time, and that's because we see this disproportionate drop-in of other lipid-lowering agents, more so in the placebo group, over the course of the study. Here's the primary endpoint, is the combination of cardiovascular death, MI, stroke, and coronary revascularization. We saw a benefit in favour of treatment with bempedoic acid, hazard ratio of 0.87. The event curves begin to separate about 6 to 9 months in, which is very consistent with large lipid-lowering cardiovascular outcome trials. And from an absolute risk reduction perspective, we saw that equate to a risk reduction of 1.6%, suggesting that 63 patients would need to be treated to prevent one primary endpoint event. If we look at the hard triple composite endpoint of cardiovascular death, MI, and stroke, we saw a hazard ratio of 0.85. When we looked at other endpoints in this study, we saw significant reductions in both fatal and non-fatal myocardial infarction. We see a significant reduction in coronary revascularization. We see less strokes in the bempedoic acid group, although this failed to meet statistical significance, although we did see a reduction in hospitalisation for unstable angina in patients treated with bempedoic acid. When we looked at fatal endpoints, we didn't expect to see a benefit in this study overall with treatment with bempedoic acid, and that proved to be the case. We saw no significant difference in the incidence of either cardiovascular or all-cause mortality overall in the CLEAR Outcomes trial. When we looked at subgroup analyses, we saw no statistical heterogeneity. We saw all subgroups appeared to benefit, in particular men and women fared equally, which was an important observation. We did seem to see that patients who were the high-risk primary prevention patient may have done better. And that was a finding that we wanted to explore further, and I'll share those slides with you in a few minutes. When we looked at safety and tolerability, we saw no significant difference between the groups in terms of the incidence of serious adverse events leading to study drug discontinuation. Predictably, we saw no excess in muscle disorders, no adverse effect on new onset diabetes. We did see patients treated with bempedoic acid, as we had seen in earlier clinical trials in this program, had greater incidence of elevated hepatic enzymes, a number of renal events, in particular raising levels of creatinine, a little bit more gout and cholelithiasis. All of that was fairly mild severity and rapidly resolved upon study drug discontinuation. We also prospectively adjudicated any incidence of tendon rupture. There'd been a numerical excess of tendon ruptures in one early small study. We decided we'd proactively adjudicate tendon rupture in this very large study, and we saw no increase in the patients treated with bempedoic acid. Just to give you some sense for where the results of CLEAR Outcomes sit in the context of other large cardiovascular outcome trials of non-statin LDL cholesterol lowering therapies, and they're very comparable whether we look at the impact of ezetimibe in the IMPROVE-IT study, the PCSK9 monoclonal antibodies in the Odyssey Outcome study, or the Fourier study, and you can see that the results of bempedoic acid for both 3-point MACE and non-fatal MI are very similar. So if we go on to look at the primary prevention data, what was the definition of a high-risk primary prevention patient coming in? They needed to have either a high Reynolds risk score, a high score risk. They needed to have patients with either form of diabetes, aged at least 65 for women or 60 for men, or the presence of a coronary calcium score greater than 400 at any time in the past. If we look at the baseline demographics in the primary prevention cohort, a little bit more women, a little bit more diabetes than we'd seen in the overall study. Baseline biochemistry was very similar to what I've shown you before. Again, the effects on LDL cholesterol and hsCRP were very similar in the primary prevention group as they were for the overall cohort in favour of treatment with bempedoic acid. What happens if we look at the clinical events in the primary prevention cohort? We see, again, a significant reduction in cardiovascular risk in favour of treatment with bempedoic acid. But here you see that the benefits looked even more favourable. For that 4-point primary endpoint MACE composite, we see a hazard ratio now of 0.7. That 3-point MACE hazard ratio of 0.64. We see significant reductions in myocardial infarction with a hazard ratio of 0.61, stroke hazard ratio of 0.76, although just failed to miss statistical significance. Interestingly, when we observe the fatal endpoints, unlike the overall analysis, here you see that in the high-risk primary prevention cohort, treatment with bempedoic acid did produce significant reductions in both cardiovascular and all-cause mortality. We've seen similar findings in the past in high-risk primary prevention cohorts, in particular the Jupiter study and the HOPE-3, where statins in a high-risk primary prevention cohort were particularly effective at reducing cardiovascular risk. Where does this all sit in terms of what the cholesterol treatment trialist analysis kind of would look like? Well, it sits exactly on the line for the whole study. Interestingly, in blue, you see the primary prevention cohort, where for the degree of LDL cholesterol lowering, it's well above the line, suggesting that there's a bigger bang for your buck. And what that means for the secondary prevention group is that we observed that they behaved exactly as we thought they would have. So predictable benefit in the patients with clinically manifest ASCVD, and what appeared to be an even greater impact per degree of lowering of ApoB or LDL cholesterol for the patients with high-risk primary prevention. More recently, we've seen a number of additional analyses that were reported at the European Society of Cardiology. We see a greater absolute risk reduction with bempedoic acid in patients with diabetes. We know that patients with diabetes have higher risk, higher event rates, good relative risk reduction, but importantly, a greater absolute risk reduction, suggesting a lower number needed to treat to prevent an event. We saw no worsening of measures of glycemic control, in particular looking at fasting glucose or HbA1c levels. And as I've mentioned before, but to kind of show it in more detail, we saw no increase in the risk of new onset diabetes in patients treated with bempedoic acid. We know that patients treated with statins, in particular high doses of statins, can demonstrate a greater incidence of new onset diabetes. We saw no such finding here with bempedoic acid in the CLEAR Outcomes trial. Another analysis that we reported at the ESC looked at the impact of bempedoic acid on total cardiovascular events. Large cardiovascular outcome trials traditionally look at a time to first event analysis. That's how they're kind of powered, and that's how we report the mainline data for those studies. But we know that there are patients within these large cardiovascular outcome trials who will experience more than one clinical event over the course of the study. And in fact, there were 2 patients that actually experienced as many as 11 events for a single individual patient over the course of the study. And what you see here are the hazard ratios on the left for first events, on the right for total events. And you can see that the hazard ratios in the total event analyses are even more impressive in favour of treatment with bempedoic acid, very much suggesting that higher risk patients who are more likely to have more events may derive a greater benefit from treatment with lipid lowering with bempedoic acid in this study. And this further illustrated on this slide, where you look at the hazard ratio in favour of treatment with bempedoic acid for patients experiencing increasing number of clinical events. And the greater the number of events that you see for an individual patient in this study, the lower the hazard ratio, suggesting a potentially greater benefit for treatment with bempedoic acid for those patients in this trial. So in summary, bempedoic acid produces effective lowering of LDL cholesterol and hsCRP in patients with and without statin intolerance. Bempedoic acid reduced MACE in high-risk patients with statin intolerance and high levels of LDL cholesterol. Greater absolute risk reductions were observed in the high-risk patients. These findings highlight the benefits of achieving more effective lipid lowering in patients with statin intolerance, a group that can be particularly challenging to treat in the clinic. On that note, I'll hand back over to Peter.
Great. Well, thank you very much, Steve and Erin, for a wonderful discussion. We have a number of questions, and we have plenty of time to deal with them. The first question I'm going to deal with, the person says, what are the risk factors associated with statin-induced muscle symptoms? So I'm going to give a short answer about myopathy and rhabdomyolysis, and I'm going to hand it to Erin to talk about the more common symptoms. So the really dangerous and dreaded muscle complications that have been associated rarely with statin therapy include myopathy. That's when we have a leakage of the muscle enzymes such as creatine kinase, or rhabdomyolysis, when we can actually get myoglobin released and have kidney complications. These are very rare, but in the post-marketing surveillance that has been compiled by the U.S. Federal Food and Drug Administration, the FDA, we found that many cases of severe muscle problems are in combination with other drugs, notably the statins, the fibrates, most notably gemfibrozil, which interferes with the glucuronidation of the lactone ring statins and raises their blood levels appreciably by blocking their excretion, their conversion and excretion. And therefore, I think that gemfibrozil should never be used in combination with statins. And actually, I'm not sure that I would ever use gemfibrozil. Fenofibrate, which is available in the United States, is less likely to cause this, but I try to avoid combination of statins with the fibric acid derivatives, except perhaps for pemafibrate, which does not have the liability of drug-drug interactions. I also would suggest measuring a TSH, thyroid stimulating hormone, in patients who are started on statin, because hypothyroidism can aggravate muscle symptoms. And I'm then, having dealt with the rare severe side effects, let me hand it over to Erin about the much more common and often non-pharmacologic muscle symptoms that are associated with statin use. Erin?
Yes. So, myositis and rhabdo are actually very uncommon. It's myalgias without any CPK elevation that's much more common. More likely to be associated with the statins if it's, bilateral, and that the guidelines don't recommend routine measuring of CPK, but they do say if a patient does have muscle symptoms that you could measure CPK in that situation. As I showed in the slide, statin associated muscle symptoms were more common in older adults. They're more common in women for reasons we don't completely understand, but women are more likely to have statin associated muscle symptoms and actually discontinue statins. And we saw in the CLEAR outcome trial, which enrolled patients with statin intolerance, that they were able to achieve, nearly half of the study participants were women. Other risk factors, we see more myalgias with higher intensity doses of statins. We also see in older adults, non-white race ethnicity, those who have liver disease or kidney disease. So those are maybe some patient groups that might be more susceptible to having statin-associated muscle symptoms.
Great, thank you. Steve, there's a question: should patients be able to skip over statins and start bempedoic acid directly, given the results of CLEAR?
Look, I think that statins are the cornerstone for our approaches to preventing cardiovascular disease. We've got a generation of clinical trials that show that they're highly effective. They're now generic, they're cheap, they're very well tolerated by the vast majority of patients, and I think certainly today, and our guidelines reflect this, that they should be the foundation for lipid lowering, and then we should try to build other agents on top of that. I think there's an increasing push for combination therapy, and that acknowledges that many patients treated with a statin won't get to goal. And I think Erin's shown some of that data in this webinar today. And so we have choices, and our toolbox has more tools, and that's great. But I think it starts with statin therapy today.
Do you want to comment on starting bempedoic acid in a patient who's had acute gouty arthritis in the past?
Yeah, look, I think that I think if a patient had severe gout in the past, this would be an agent that I would probably not use. I think we have other options, and I think that does speak to what's in our toolbox. We did see a little bit more gout in this study. As I said, most of those episodes were very mild, and they did resolve very quickly. But I think if that patient had a history of fairly significant gout, then I would probably look to use another agent.
Great. So, Erin, a lot of patients who are statin reluctant will come in and say, I'd like to take coenzyme Q10. And someone asks what our stance is on CoQ10 administration as an antidote to statin muscle symptoms.
Right. So the 2018 ACC/AHA guidelines don't recommend universally CoQ10. That the data really hasn't demonstrated a clear benefit, so we don't recommend it or prescribe it sort of prophylactically. That being said, I have some patients that swear by it. They feel that their symptoms got a lot better with CoQ10, and they really want to take it. And so I just want them to be adherent to their statin. So even if it's a placebo effect, if it's going to be more likely that they stay on the statin because they feel better, I don't, discontinue it or discourage them from taking it. But I don't go out of the way to prescribe it. That's the guidelines don't give a recommendation. It's actually a class 3 to, prescribe this routinely. The question comes up about vitamin D. Unfortunately, the data has not really been convincing that vitamin D supplements can, reduce statin-associated muscle symptoms. There was a sub-analysis of the VITAL trial, which was a primary prevention trial evaluating 2,000 international units of vitamin D compared to placebo. And this was just a secondary analysis, but in this randomized clinical trial, there was really no difference in statin-associated symptoms for those randomized to vitamin D versus placebo. So there's not really strong evidence that that can reduce statin-associated muscle symptoms either.
It certainly is an observation that coenzyme Q levels in the blood will go down on statins, but that's simply a matter of they're being carried by the LDL particles primarily, so that when you drop the LDL, you're going to drop the CoQ10. But that certainly doesn't mean that you're going to get protection. So, Steve, you made the point that a not insubstantial number of the participants in the CLEAR outcome trial were on a low dose of statins. Were they also on ezetimibe? Someone in the audience wishes to know.
Small numbers on ezetimibe, and the reason we allowed the low dose of statins was we thought that maintained the scientific integrity of the study. I think Erin highlighted the data from the Cleveland Clinic observational study, and I think a broader message. I think these patients are challenging, and I think that we're playing an N=1 game every time we meet with those patients in the clinic. And so whatever we can do to get them to take some form of statin to try to maximize the dose, I think is a good thing. If we can then start to look to combination therapy, then that would be that's even better. And I think now we have multiple options that allow many of these patients to achieve the LDL targets that they've really struggled to get anywhere near in the past.
So, Steve, here in the US, we have a fixed dose combination that is marketed with bempedoic acid and ezetimibe, which really helps to address polypharmacy. So I wonder if you can comment on the use of the fixed dose combination, whether it's available in all markets.
It's not available in all markets at the moment, but we would be hopeful that will be very much the case. As I showed earlier on, the genetic data would suggest that we would see a benefit. We know that there's more LDL cholesterol lowering. The benefits and clear outcomes are directly related to how much you lower LDL cholesterol. So one shouldn't be too surprised then to think that a fixed dose combination would be more effective at lowering LDL cholesterol and therefore would be more effective at lowering cardiovascular risk. And I suspect that where bempedoic acid finds its place out of that clinical toolbox is more likely to be in use as a fixed dose combination, because, as you said, it will be a very convenient way to be able to achieve 40 to 45% lowering of LDL cholesterol in many patients.
Which is about what you get with a moderate intensity statin dose. So it's a real, I think, important piece of the armamentarium that we have with the combination therapy. So there's concern about liver enzyme elevations with statins. And Erin, is this something which you've encountered with your patients? I've had patients come and say, well, don't statins do a job in your liver? And is there any signal for hepatic toxicity with bempedoic acid? And what's your stance when patients say that they're concerned about the liver problems with statins?
Yeah, so severe hepatotoxicity is incredibly rare. In fact, it's so rare that the FDA has said that you don't need to routinely measure liver function tests on statins, although we certainly would measure them before starting ezetimibe. That being said, to help alleviate my patients' concerns, I usually always do get a liver panel when I'm checking my repeat, lipid profile after initiating therapy to provide reassurance to patients. It's important to also know what their baseline tests are, because many patients have, non-alcoholic fatty liver disease, metabolic associated liver disease, and actually in those cases, sometimes statins are even beneficial in treating their cardiometabolic risk, and in some cases, the numbers even improve. Statins are not contraindicated in patients with chronic liver disease. If you have a patient with chronic liver disease who also has atherosclerotic cardiovascular disease, we still recommend continuing with statin therapy. You might certainly want to hold it or not initiate it if there's acute hepatitis or an acute liver injury, but they can be used in patients with chronic liver disease safely.
That's really great. Um, so important question, Erin, I'd like your comment on is that in the CLEAR Outcomes trial, as in many cardiovascular trials, the majority of patients are Caucasian. And is there a worry that bempedoic acid's efficacy or side effect profile might differ with race or ethnicity?
Well, first of all, it's very important to try to improve diversity in clinical trial enrollment. We want to make sure that the results of trials, which is what our guidelines are based on, the evidence from randomized clinical trials, because they serve the greatest evidence base. We want them to be representative of the broad patients we care for in clinical practice, and particularly, we see this historically. Women are under enrolled in cardiovascular clinical trials. They're usually only about 25% of participants. And so I was really pleased to see, at least with CLEAR Outcomes, that there was near parity, near 50% women. We certainly want to enroll diverse racial ethnic groups. I think that race is more of a social construct, and it may be capturing other vulnerabilities related to social determinants of the health rather than genetic differences or biological differences. But indeed, it's important that we try to improve our representation in trials to make sure that our therapies are working broadly in the patients we see in populations. But we know that LDL cholesterol is causally related to atherosclerotic cardiovascular disease, in all of, race ethnic groups that we evaluate. We've seen this in multiple studies. And so, and the studies where we have looked at this, they seem to drive, similar benefit with LDL lowering with therapy. So I don't have any reason to believe that bempedoic acid or other LDL lowering therapies would not be effective at reducing cardiovascular outcomes in non-white populations. But we all need to do better in clinical investigation to try to improve recruitment of diverse populations in trials.
All right. Well, thank you very much. On behalf of the International Atherosclerosis Society, let me thank all of the people who've joined this webinar and thank our speakers, Erin Michos and Steve Nicholls. I certainly learned a lot from this discussion, and I hope our audience did too. So stay tuned. We'll hope to have you join a future webinar sponsored by the International Atherosclerosis Society. Thank you so much.